मन बलवान लागे चट्टान रहे मैदान में आगे जो झुंझार होते
ऑर्डर कौन देगा?
दादा चांगलं आहे ना? हां
अरे ह्याची तर अशा माझ्याकडे अवेलेबिलिटी
lot of you will start doing. Remember, the bevel of the needle should be down. There's a lot of backflow and a lot of product wastage. So inject slowly. Make sure that you are going in the right depth. It has to be deeper than what you inject for aesthetic indications because you are going the skin, the thickness of the skin is more over here. You can use up to 50 units on each palm. This is a very, very painful injection. If you have the facility, go for nerve blocks. In my practice, I usually just put the numbing cream. Here, patients are more motivated than ever, so you can definitely go ahead. Now,
using the most lethal toxin which leads to muscle paralysis. Briefly, I will tell you about the structure that we see here. It is a 900 kilodalton molecule with a core neurotoxin of 150 kilodalton. There is a heavy chain and a light chain which are bound together by the disulfide bond. Surrounding them is the non-toxic, non-hemoglobin pharmacological properties and structure. The differences that we see which divide them is those toxins. We go to the next slide. These include the ibobotulinum, the onabotulinum, the prabotulinum and the letibotulinum. These have in addition some products. Also some contain the flagellin and the bacterial DNA. inactive toxin molecules. So,
and there is a small blip. So the depth of the injection can be either an intradermal or dermal or into the muscle. There is no much variation. The results are equivocal. This is how you distribute the toxin in the forehead. And this is study which has nice. The eyebrows also get arched very nicely. So you improve the arching of the eyebrows. You need directly here, and that relaxes or drops down the Mephisto sign. Muscle, but to ensure that you are not injecting into the orbital ring, and it's directly into the muscle, and you inject about 4 to 5 units into the corrugator. The point medial here in the corrugator will be perpendicular. It goes directly into the muscle, action into the muscle process. So the dosages vary between 4 to 6 units into the process. And when you are injecting the medial, so you can inject about 3 to 4 units into the head of the corrugator, and into the tail you can inject about 1 to 2 units depending upon the thickness of the muscle. So this area is a little bit painful. Be careful because you have a lot of nerves there, the supratrochlear, the supraorbital. You are not injecting adjoining muscles when you are doing this small area. So why should we? And this muscle when you are injecting can actually cause distortion of the smile. So when we are treating, actually we are actually treating into
which we have, which is where, due to which we chew a lot, and there is mesenteric hypertrophy which gives rise to a thickening of the jaw. So due to which you can inject in the masseter, but what do we need to be careful about? That you need to be at least. But microbotox technique will give you good skin texture, smoother horizontal creases. It will decrease the vertical banding of the neck, and you are able to get a.
I am Dr. Janisha Anand Jain, and a disclaimer alert, I have recently passed my post-graduation and I'm working as a senior resident. So I am giving this disclaimer because my further talk may sound a little juvenile, but kindly spare me because this is from the perspective of a postgraduate doctor. So come with me as I tell you about my biggest surgical blunder, and let's count my red flags with me, or rather the blunders. So when I talk about my biggest surgical blunder, my mind goes back to my first year of post-graduation. I had just entered my first procedural posting, and I was armed with enthusiasm, empathy, and a dangerous lack of experience. So with all these weapons, excited me and my senior, we counseled one patient with vitiligo, with segmental vitiligo for vitiligo surgery. Now what differs between the experienced surgeons whose sessions we have attended in the morning today and an enthusiastic PG like me is patient selection. So well, on that very day we decided we were going to do a suction blister graft surgery for about an 8 by 10 centimeter patch, depigmented patch on the thigh lesion. Now you wonder why suction blister? Well, not because it was the best choice of surgery in that patient, but probably because we wanted to learn something new. And that was my red flag number 1. Moving ahead, on the day of the surgery, I was extremely excited. I got up early, got into my scrubs, reached the OT, prepared everything, prepped the patient, did everything even before the staff and my seniors had arrived. And I was all set to go. And there came our red flag number 2. We decided to replace the standard syringes with the hijama cups. Well, you will again wonder why hijama cups? Because inexperience in us thought that bigger cups would probably mean bigger blisters, better blisters. We'll try to finish the surgery faster and we'll be like very efficient. Only time was to teach us our lesson. So I measured the recipient area, I exactly placed the cups to cover almost a 1:1 ratio of the donor area. And we set the pressure and we waited. Minutes passed and they became hours. The clock kept ticking, but the blisters were nowhere to be seen. It was about almost 3 hours, and in the meanwhile, I thought, let me be a more efficient PG. Let me prepare my recipient area, keep it ready. As soon as my blisters will come, I will harvest them and we will finish it off. And I did prepare my recipient area in the meanwhile. And about after 3 hours, the patient started complaining of pain on both sides because the local anesthesia was now wearing off. So again, as I said, the empathy in me and the inexperience, I thought, let me give her some pain relief. So I injected a little more local anesthesia. No counting, no maximum dose, sheer pain relief and more pain relief. This was my red flag number 3. Just when I thought nothing would go wrong on this day, already, the procedure had exceeded the time we had thought it would take. We were 4 hours into the procedure. Blisters were nowhere to be seen. We were all, it did seem a little chaotic, not sure how to progress further. That's when the patient said that she feels nauseated. I was trying to talk to her, and in the meantime, she vomited. Right there in the OT, she vomited. Yes, you heard it right. And that's when the final panic set in. We somehow calmed the patient down, gave her some antiemetics, cleaned the area, and what seemed like a never-ending surgical procedure, finally we saw that the blisters, the cups we had applied now had some tiny blisters. That gave us a little bit of ray of hope, and we thought, okay, we'll fuse them now with normal saline. We'll harvest the graft and use the graft. And that's exactly what we did. Of course, to our surprise, now the donor's tissue was much lesser than the recipient dermabraided tissue. And now that happened because as we used the bigger hijama cups, we were not really sure of the pressure, like it would require more pressure than we would have used for the syringes. Well, because pressure is inversely proportional to area, a basic middle school physics, but it seems I had forgotten all of this on the day of my surgery. So any which way, surgery, I realize, is about commitment and reaching the finish line, and you cannot give up whatever it is, how many ever obstacles you have to reach the finish line and complete the procedure. So then we decided, okay, let's go ahead with mixing a smash graft with a suction blister so that at least we can improvise on our surgery, and that's what we did. The surgery almost got over by 3:30 p.m. and we had started this at 8:30 in the morning. It lasted than most of the major surgeries that general surgeons do. And that was really, what kept us going through that entire day was the patient, her trust in us, her strength, her resilience. We did follow up with the patient after about 3 months. She did develop pigmentation. Vitiligo surgery was a little forgiving that time to us, but I know that we had simply been very, very lucky. That one day taught me a lot of things. That one evening, I was discussing this case with my anesthetist friend, and I just happened to tell him what happened in the events of the day. And he was listening very patiently when he just asked me one question. How much local anesthesia did you inject? And I squinted at him and said, I guess like vaguely 1 bottle. And he said, did you inject 30 ml in a patient of 35 kgs? And I said, roughly. Why do you ask? And that's when he said that the nausea that your patient had could have been a toxicity to the local anesthesia, and you have been super lucky that it did not get worse. You were not armed to manage that complication. You were not armed to manage a CNS complication. It could have been way worse. That gave me chills down my spine. I'm still getting the chills. I'm still very, very petrified of that thought. But as I said, we had been very lucky. However, as I said, patient did follow up. She did develop pigmentation. She did return with a smile. But that one day taught me a lot. It taught me my 3 lessons that I am never forgetting. Number 1, never not know the maximum dose of any drug that you inject, that you are going to prescribe. It's a blunder. Second, what differs, as I said, between an expert and an enthusiastic post-graduation is patient selection. Many a times when you select the correct patient, even average skills can shine. But many a times when you have a wrong patient, even expert skills may not give you optimum results. And finally, before you try to improvise or use a modified technique, it's crucial, very, very crucial that you have done the basic procedure multiple times to understand how the procedure may flow. And with that inexperience, I did gain a lot of experience in that. And These were my learnings. Was this my biggest blunder? Absolutely. But was it my greatest teacher? Definitely. And Munish Paul sir had said in the morning today that colleagues should avoid these disastrous results in vitiligo surgery. And I'm not proud to say, sir, if you are here or you listen to me, that I am extremely apologetic, and I'm glad that now I have improvised, I have attended many workshops. I am now well equipped to understand how I'm supposed to deal with a surgery, with a procedure, and that's it. Thank you.
She actually really is the reason why I'm here speaking as a dermatosurgeon, because she really identified my single passion, and that was to do surgery. Right in the first year when I was doing DVD, at that time DVD was just 1 year. So we had an exam in January, and in December was the first ever conference of dermatosurgery in India. At that time it was called ADSI, the predecessor of ACSI. And Dr. Bhutada would know better because, so you were there at the meeting, yes. It was a wonderful exposure. It was just a month before the exam, so very tense, but ma'am chose me to represent our department, and I refused to go alone, so I had to take my colleagues, Dr. Vinay Gopalani and Josna Dev. We all three of us went, all first yearites, to this meeting. Madam actually created a dermatology plastic surgery clinic wherein we would discuss things which could be surgically treated. It was just because every time, right from first year, I would actually keep on saying, why don't we treat it surgically? Why do we need to sit and just apply creams for months and years and wait for these things to change? And so we went into this clinic. The surgeons would come down once a week. We would see their cases. They would say, okay, this is to be done, and I would get a chance to go into the OT, see how they were doing it. So there's a lot of things to learn from them, suturing techniques, their choice of instruments. Everything was ordained because in my department there was not a single person who could handle a scalpel. Teach us, actually he would teach me and then I would teach my juniors, so that's how we transfer the knowledge. After this, madam actually recommended me, or rather actually I asked her and insisted that I need to go abroad to learn dermatosurgery. So for every small thing, a little BP going up or down, we would rush to the medics and ask their help. So it actually helped me to understand how I can manage things on my own. Moving on from UK, well in UK I did a huge amount of work in surgery, in dermatosurgery. Skin cancer is president of the British Society for Dermatologic Surgery, and he was actually the one who started thread lifts, Botox, fillers of different types, different ways of doing these things. So there's lots and lots of things in dermatosurgery which we can learn, and you have to be, what I'm trying to actually put force upon here is that we need to identify the right people to teach you the things. And when you go to the right people, you actually, so you need to work on your skills for years, and then you become a good dermatosurgeon. So it takes multiple years to, multiple procedures at the same time to become an expert. So today I'm standing here in front of you and asking you to, especially the juniors, to actually identify the right teachers and go to them and learn things from them. Thank you all very much.
And it becomes a little tense, then you know that there's sufficient local anesthesia. You can also administer anesthesia along the surrounding margins, put an incision along the linear long axis of the lesion or RSTL. This is an extremity lesion, and then a little bit of undermining just to release the overlying epidermis so that it can easily be popped out, not too much. Sides with the index and thumb. Sometimes if in case of larger lesions there can be deeply anchored enough lesions, so it's a little difficult since enough basically tumor arising from the nerve sheath, so it has some sort of deep anchoring also. So once the tumor and little bit of tumor is extruded by spacing, you can now gently look for the deep dermal tail. So deep dermal tail, and then you can just excise the entirety of the tumor. So the advantage the quality of life of these individuals. Standard treatments include surgery, lasers, photocoagulations, and RF ablation. Electrical excision. Buttonhole sign is nothing when you push the neurofibroma mass, the finger or tip of the forceps, it kind of goes into the dermis and then it pops out because of its elasticity. And this is because of the nature of the tumor per se, because of the still overlaying epithelium, and then squeeze and pop the tumor mass to gently pop out from the underlying dermis